So we're going to start off today, as has become tradition, with just an intro to Project Echo and to age-friendly care. And thanks to those of you who already put your name and role in the chat. It's great for us to build some community here. All right, so what I'm going to go over here at the beginning, we always start these sessions with a mini didactic, the first 15 minutes, and then the rest of the hour is a case discussion where someone submits a case and we all talk about it together, and we have an interprofessional panel that'll introduce you all to. So what I'm going to go over for these first 15 minutes or so is to explain the context of Project Echo Geriatrics, what is Echo and what we're trying to do here, describe age-friendly healthcare and that paradigm, and then talk a little bit about the nuts and bolts of Echo participation, just as by way of orientation. So the Echo model isn't something I made up. That it stands for the Extension for Community Health Outcomes. And it was developed by this doctor, Dr. Sanjeev Arora, who is a liver disease specialist at the University of New Mexico. And back when he started the Echo model, he had this problem where he was one of the only providers in the entire state of New Mexico who was providing care for hepatitis C at their academic center. And patients were having to wait a very long time, 6 months or more, to see him, were having to travel long distances, and it created a lot of barriers to care and a lot of health disparities. So his idea was to use video conferencing, much like you're on today, to train primary care providers throughout the state in providing the hepatitis C care themselves. And so they had a mini didactic case discussions, met regularly. And over time, these primary care providers became very expert in the care of hepatitis C. And when they studied it, the outcomes for the patients they cared for were just as good, if not better in some ways, as those compared to those patients who were treated at the academic center. So this really launched this model as an innovative way to provide specialty care in primary care. And since then, it has spread extensively throughout the world. And by 2022, about a decade after the Echo model launched, there are almost 500 hubs throughout the world providing Project Echo training to a variety of folks. And it's being used for many topic areas, not just hepatitis C, but HIV, geriatrics, palliative medicine, substance use disorders, and this word cloud just gives you a taste of that. And it's also used outside of medicine. It's been used to train K through 12 educators and first responders. It's really a great model with a lot of purposes. So why are we doing this for geriatrics? Well, you all know that the older adult population is rapidly rising, but unfortunately, the number of geriatricians is not rapidly rising to keep up with that. There are only about 7,000 board certified geriatricians in the United States, and you can see that as compared to other specialties. And geriatricians could never provide all of the care needed for complex older adults. So it's really everyone's role to provide high quality care to older adults. And part of my role as a geriatrician is to disseminate the additional knowledge I learned through my fellowship training and practice and share that with as many people as possible so that wherever someone gets treated, whenever an older adult seeks care, they're getting the best quality care. We launched Project Echo Geriatrics to meet this need back in 2016, in January of 2016, and every month since then, we've run a session like this. They're 1 hour each, and they have a mini didactic and then a question and answer period. But the heart of Echo and the heart of these sessions is the case discussion, where we're going to be talking about 1 or 2 cases per month, complex older adults, a lot going on, and we'll all talk together and with the interprofessional panel about what to do to provide the best care for this patient. There are a lot of gaps in the quality of care for older adults, and I'm going to step back a little bit and talk about age-friendly care and why it's needed and what some of the problems are today that the age-friendly care movement is trying to address. These are just some examples of poor quality care for older adults. For example, over 30% of older adults each year are prescribed potentially inappropriate medications. These are medications that can lead to falls or cognitive impairment, for example. Falls in this country lead to over 2.8 million injuries that are treated in emergency rooms annually and lead to over 800,000 hospitalizations per year. And this is despite the fact that falls are largely preventable. Only about 50% of those who have dementia are diagnosed with it and have a diagnosis in their chart, which makes it really hard to do evidence-based care for dementia, do advanced care planning, and provide evidence-based treatments. And all of this is happening despite the fact that older adults spend a ton of time interacting with the healthcare system. It's estimated that older adults spend about 17 contact days per year engaged in healthcare. That could be a visit to a clinic, a meeting with the physical therapist, working with the physical therapist in clinic, going to the lab to get their blood drawn. So 17 days out of the year, older adults are spending doing this. But it's not the quantity of care, it's the content of that care and the quality of the care that they're receiving. So in response to this, the Institute for Healthcare Improvement and the John A. Hartford Foundation back in 2017 put forth this bold vision to say we need to rapidly transform care to be more age-friendly, to be of higher quality. And they partnered with others to do this and have launched this movement that has spread very quickly. And many of you are likely familiar with this. So what is age-friendly care? Age-friendly care follows an essential set of evidence-based practices, or the 4 M's that I'll come to in a second. It causes no harm, and it aligns, most importantly, with what matters to the older adult and their family caregivers, the care that they want that helps them do what they want to be doing in their lives. The 4 M's of age-friendly health systems are what matters, medication, mentation, and mobility. I'll describe those in a little bit more detail. So where do these all come from? Well, we have a lot of evidence-based care models for older adults, things that prevent delirium, things that provide the highest quality of care for dementia, models of care that prevent falls. But there's a growing gap between what we know from these models of care and from the evidence and what we're doing. And the age-friendly health system movement is trying to close that gap really rapidly since the older adult population is growing so rapidly. So how did they pick these 4 M's? Well, they looked at evidence-based models of care and said, okay, what are the features of these care models? And then they distilled it down to 13 care features that were common across many of the evidence-based models of care for older adults. And then they were really clever because they realized that no one's going to remember the 13 M's of age-friendly care. So what are the most important ones, and how could we consolidate that into something that's easy to remember and has the most impact? And that's where the 4 M's of age-friendly care came from. And again, those are what matters, medication, mentation, and mobility. So what are these? What matters is really at the heart of age-friendly care. And it's knowing and aligning care with an older adult's health outcome goals and care preferences. And this does not just include end-of-life care and discussing end-of-life care, but what matters to them now? Do they want to be able to go shopping by themselves? Do they want to be able to walk their dog? Do they want to be able to spend time with their grandchildren? Do they want to volunteer down the street at the local thrift store? Whatever it is that they want to do, how can we align their care to help them achieve that goal? Medications, that M refers to knowing what medications an older adult is on, reviewing those. If a medication is necessary, using age-friendly medications that don't interfere with the other M's, that aren't causing cognitive impairment or falls. Mentation is preventing, identifying, treating, and managing dementia, depression, and delirium across all care settings. And mobility is making sure older adults can move safely every day to maintain their function and do what matters, preventing falls and maintaining the highest level of function. There are a few key points to know about these 4 M's of age-friendly care. First of all, it's a framework, it's a paradigm. It's a way of thinking about the approach to care, and they're meant to be implemented together and reliably, meaning every older adult gets all 4 M's assessed and addressed. And they can be implemented across entire healthcare systems or at an individual clinic or provider level. So you can do it broadly, or just any of you could provide age-friendly care by yourselves. They should be incorporated into the existing care rather than layered on top. So you don't want to provide primary care and then do this age-friendly thing separately. It should be woven into what you're doing. And finally, the tools used to implement the 4 M's may vary. You might use different fall prevention screening tools. You might use different depression screening tools, for example. But as long as they're based in the evidence and work with your setting, it's fine. There were 5 health systems that pioneered rolling out the assessment and action upon the 4 M's for older adults. And some of you are part of these. We often have folks from Kaiser and Providence, for example, on these sessions. And many of you have implemented age-friendly care, and our official age-friendly care clinics are working in them. So you're familiar with this. But these groups pioneered this care and worked out a lot of the kinks, and all of us are benefiting from that. But you can see by now, 2022, there are almost 800 sites that are officially providing age-friendly care, and the Institute for Healthcare Improvement has recognized them as such. You can apply for age-friendly status, and then they list it on the website. To operationalize the 4 M's, it's important to think about the fact that for each of these, to provide age-friendly care, you're assessing them and acting upon them. So just doing fall screening, although important, isn't age-friendly care unless you're acting upon what you find. The same with depression screening or screening for cognitive impairment. So it's assessing and acting upon. There's a great guide to age-friendly health systems, the guide to using the 4 M's on the IHI website. The URL is here, and we'll send it out in the resources afterward. It has a lot of ideas for how to make this work in any healthcare setting, and also gives you suggested tools to use. So let's go and let's talk a little bit about Project Echo Geriatrics. We really talk a lot about the 4 M's of age-friendly care, and a lot of what we're discussing really applies directly to it, and we'll be providing tools for both the assessment and action on the 4 M's throughout the year. We have a great interprofessional team. High quality care of older adults is a team effort. And so you'll see we have a really great interprofessional team that I'll introduce you to later. Every month, as I mentioned, on Project Echo Geriatrics, we will have cases. It's the heart of Echo, and we ask you to submit cases when you have them for discussion. We had a volunteer for today, and thank you for that. But if you're going to be submitting a case, just a few tips and tricks here. We love cases that are primary care focused, although that's not 100% necessary, but since a lot of the focus of what we're doing here is primary care, that's always great. Anyone can present, anyone from the care team can present. You can invite trainees to present as well. It's okay to leave sections of our case form blank. It's pretty comprehensive, but you don't have to feel intimidated by that. You don't have to fill out every section, just the ones that are relevant to you. Please de-identify everything that you put on the case form. We ask for them 48 hours in advance of the session. You could submit them anytime before then. And we would love for each of you participating at a site where there are multiple participants to submit at least one case sometime between July and June. And Amy has a sign-up sheet that she'll send out. She sends the case form to everyone and also sends it in the reminder email, so it's easy to track down. We send a resource email after each session, and that makes it so that you don't have to furiously write things down during our sessions of the resources. We try to put them all together and email them out afterward, and this is an example of one of those resource emails. Just a few final notes on Project Echo. I love when you have your video on, especially during the case discussion, because then we get to know each other. I do understand that some of you join from places where you cannot do that, and that's fine, but feel free to eat your lunch while you're on the session or whatever you want, whatever you're doing. I want to build some community here, and we have over the years, and having your video on is part of that. Invite your team and anyone from your interprofessional team to join. And if you have trainees that are working with you, if you have a student working with you, even if they're just going to be able to join for one session, that's great and fine. Please feel free to invite them. And this is an all teach, all learn model. So all of us are going to be learning from each other. I've learned a ton from all of you over the years. And although we have a great expert panel, all of you are part of the teaching and the case discussion. So please join in the case discussions and add your expertise. So that's all I have to say about Project Echo Geriatrics for now, for the introduction. I think that together we will make healthcare more age-friendly, and I really appreciate all of you taking the time to participate in the Echo sessions and to contribute to them, because it's moving things along and helping improve the care of older adults. You can reach out to me anytime. My email's on this slide, bennett4@uw.edu. If you have a geriatrics question, whether it's a where do I find this resource, or what do I do about this patient, or can you remind me what you said about this or that, reach out anytime. I'm happy to answer questions. I get really excited when someone emails